Next up, we have Dr. Katherine Hendy. Dr. Hendy is a medical anthropologist and science studies scholar whose ethnographic research spans genomics and psychiatry, social justice and cannabis, and the medicalization of psychedelics. Her scholarship is centered on using ethnographic methods to investigate the epistemic and political claims that animate discussions of drugs and pharmaceuticals. Please welcome Dr. Katherine Hendy.
There we go. All right. Good morning, everyone, both in person and online. And thank you to the organizers for giving us this lovely opportunity to talk together today, actually in person, which still feels like such a treat. So my talk today is called Placebo Problems Redux, Mistrust and Boundary Work Amidst the FDA Hearings on MDMA-Assisted Therapy. Try and juggle two computers. We'll see how this goes. So on June 4th of 2024, the United States Federal Food and Drug Administration held a historic meeting of their Psychopharmacological Advisory Committee on the new drug application of Lykos Therapeutics for MDMA-assisted therapy. The meeting was the culmination of almost 40 years of advocacy work by the Multidisciplinary Association for Psychedelic Studies, or MAPS, which gave birth to Lykos Therapeutics, and over 20 years since the FDA approved the first MDMA-assisted clinical trial. However, the contentious meeting would lead to the committee voting against approving MDMA-assisted therapy and ultimately to the FDA rejecting the application and requesting further studies. The FDA's meeting lasted almost 9 hours and featured a far-ranging set of discussions, debates, and fundamentally deep critiques about the Lykos trials. It would take more time than I could possibly have today to get into the issues raised, like a tenuous distinction between licit and illicit MDMA, questions of vulnerability and agency of participants on psychedelics, and debates about access and equity. What I want to focus on today are the debates about functional unblinding that the FDA placed at the center of its discussion of the efficacy results, which they acknowledged were positive. After presentations from both Lykos and the FDA, as well as a public commentary, the FDA asked the committee to discuss the following question. Discuss the evidence of effectiveness for midomethamphetamine, or I'm just going to use MDMA today, for the treatment of post-traumatic stress disorder, and consider the following. The potential effect of functional unblinding on the interpretability of efficacy results, the durability of effect, and the role of the psychological intervention in the treatment paradigm. Functional unblinding, for those not familiar, is when participants and researchers in a clinical trial are able to tell whether or not they received the drug being studied or the placebo. In research with psychedelic therapy, the functional unblinding is due to robust changes in perception and emotional state that occur with these substances. Functional unblinding then calls into question whether or not the results of a study are due to the therapeutic intervention itself or to what is known as expectancy effect, which is the degree that participants may bias the results because they, in essence, know what they're getting. Thus, these discussions cut to the heart of whether the results in the study could truly, for the committee, be trusted. Discussions of functional unblinding and placebo controls have haunted psychedelic studies since the 1960s, when the randomized controlled trial, or RCT, was given institutional and scientific legitimacy. As I'll talk about further today, historian Matthew Oram has argued that it was the inability of psychedelics to fit into the ascendant model of the RCT and its corresponding magic bullet model of pharmaceutical efficacy that led to the gradual cessation of psychiatric research with psychedelics. However, today I want to argue that the committee's debate about functional unblinding is distinct from the mid-century debates. Rather than discussions about unblinding being used to delegitimize the efficacy of psychedelics, the discussion centered on the legitimacy of the therapy itself, which committee members criticized for a lack of standardization. These discussions about standardization did multiple types of work. They sought to bring psychedelic therapy into alignment with the kinds of standardization that work in contemporary psychiatry. They sought to make visible the efficacy of the drug by stabilizing the work of the therapy. And they sought to find a way to build trust in the therapy amidst a set of allegations of ethical misconduct. Ultimately, they hinted at a trust in the drug and a mistrust of the therapy and therapists. There we go. So, psychedelics, placebos, and psychiatry have been entangled since the mid-century. In the 50s and 60s, when Sandoz Pharmaceuticals first began to distribute LSD and later psilocybin, researchers studied psychedelics as a treatment for a range of psychiatric disorders, most notably alcoholism and schizophrenia. During these years, researchers developed a technique called psychedelic therapy, which involved a single large dose of a psychedelic in conjunction with psychotherapy. The large dose technique of psychedelic therapy was supposed to induce a new perspective on one's life. In contrast, psycholytic therapy used smaller doses to induce dreamlike states in which material from the unconscious could surface. And in psychedelic chemotherapy, there was little to no psychotherapy during a session. As the term chemotherapy implies, it was only the effects of the drug. As historian Erica Dick has argued, these emergent techniques seem to bridge the gap between the rising interest in pharmaceuticals and psychiatry. Intertwined with this timeline, the discipline of psychiatry was shifting toward biologically based pharmaceutical treatments. Gradually, the individuated psychodynamic model of diagnosis and treatment was replaced by institutionalized standards with set diagnostic criteria and corresponding psychometric testing. Part of what continues to make the contemporary moment so significant for psychedelics is not simply that they are once again being studied as therapeutic treatments, but that they are being studied in randomized controlled studies approved by the FDA. Recent historical scholarship by Matthew Oram has argued that research on the therapeutic use of psychedelics slowed down in the 60s, due in part to changes in federal regulation of clinical research. There we go. The 1962 Cafaro-Harris Amendment institutionalized the requirement that new pharmaceutical treatments first demonstrate safety and efficacy in quote-unquote well-controlled trials. However, Oram argues that the ambiguity of what did or did not count as well-controlled gave the FDA further authority over trials themselves. However, post the Cafaro-Harris Amendment, regulators had a strong preference for double-blind, placebo-controlled trials. The call for these controlled trials met resistance among psychedelic therapists. Researchers posited that the complex relationship between the pharmaceutical and the psychological aspects of the drug made it difficult to study in a double blind. Despite these difficulties in the mid-60s, there were a series of controlled studies looking primarily at psychedelic therapy as a treatment for alcoholism. Most notable were the Spring Grove Psychedelic Research Program, which looked at the efficacy of LSD using randomized controlled trials. However, the results of Spring Grove studies were inconclusive, and researchers faced difficulties in implementing randomization and control condition. In contrast, studies using psychedelic chemotherapy found negative results. Because the psychedelic chemotherapy matched the magic bullet model of drug intervention in which the pharmaceutical does the work, psychedelic therapy lost favor. While studies with no therapeutic intervention were used to discredit psychedelic therapy at mid-century, in this next section, I want to talk about how the debates at the FDA committee focused on the therapy itself as a site of potential standardization that might make the full efficacy of the therapy more easily studied. During the committee meeting, Lykos Therapeutics presented data from two different clinical trials using their own manualized therapeutic process and placebo controls. The Lykos therapy model draws upon the techniques of psychedelic therapy in that a large dose is administered in conjunction with an ongoing program of psychotherapy. For both studies, they used an inert placebo for the control arm, but the same manual psychotherapeutic process, meaning that some participants received MDMA plus psychotherapy and some participants received a placebo plus psychotherapy. The psychotherapy itself is open-ended by design and draws on multiple therapeutic techniques. All therapists were trained by MAPS, and videos of their therapy sessions reviewed to ensure that they followed this manual. However, the use of the inert placebo raised questions during the meeting about how much functional unblinding impacted the results. In contrasting presentations, Lykos argued that their studies demonstrated statistically robust and durable evidence of the effectiveness of MDMA-assisted therapy for PTSD, and that psychedelics face fundamental obstacles in blinding. The very fact that substances like MDMA produce robust changes to how people perceive and feel about the world around them means that functional unblinding will always be a part of clinical research on psychedelic therapy. Furthermore, they argued that the trial design had been approved by the FDA and that the FDA was well aware of the issues. The FDA rejoined by pointedly saying that their concerns about functional unblinding had been ongoing, but they also opened a door, noting that it may be possible to have a well-controlled study with functional unblinding. A study that is functionally unblinded may still be considered as an adequate and well-controlled study. However, the potential influence of bias needs to be factored into the interpretation of study results. With this statement, the FDA set up a debate and discussion about how much the panel could rely on what at first glance was robust evidence of efficacy. The efficacy data was critiqued from many angles, that there was not convincing evidence that results would last, that there were no measurements of the degree to which participants had expectations of efficacy. However, also woven in were discussions of the therapy itself. Unlike mid-century when the therapy was written off as superfluous, the necessity of the therapy was an acknowledged part of the discussion. And I want to argue that in these discussions of functional unblinding, the role of the therapy came to do multiple kinds of work. They sought to bring psychedelic therapy into alignment with the kinds of standardization that are work in psychiatry. They sought to make visible the efficacy of the drug, and they sought to find a way to build trust in the therapy amidst a set of allegations of ethical misconduct. So to return briefly to the question that the FDA posed to the committee, which was first to discuss the evidence of efficacy, but to consider the potential effect of unblinding, the durability of effect, and the role of the psychological intervention. With that final subpoint, the FDA put the therapy at the core of the evaluation of efficacy data. The committee, which had both standing members and others who were called on for their expertise in pharmacology and PTSD, launched into a discussion. Oh, that's what I wanted. All right. Walter Dunn, a psychiatrist with expertise in mood disorders, began the discussion by noting the role of the psychological intervention. That is one of the key issues today. We don't have a 2x2 factorial design, which would make the question easier to answer. In calling for a 2x2 design, Dunn was calling for not only a comparison of MDMA placebo, but a comparison of different therapeutic techniques. Dr. Paul Holzheimers, who is a deputy director of research at the National Center for PTSD, said, the psychological intervention is a bit of a black box. It's an ill-defined intervention that would be hard to define across aims and could contribute to differences across arms. Here, Holzheimer essentially called for standardization of the treatment so that one could account for differences in efficacy across different treatment groups. Dr. Melissa Decker-Barone, another psychiatrist from the VA, stated, as far as the psychotherapy goes, the way that it is presented in the data makes it impossible to disentangle the two. MDMA is not administered without the psychotherapy, and the psychotherapy was vague. It was not well determined. It seems like it was not standardized, and that makes it really hard to determine how effective it was. Finally, Dr. Amashahi, a professor of emergency medicine with a pharmacology background, chimed in, first noting that the difference in her disciplinary background made this panel difficult. After noticing that there was an efficacy signal, she went on to offer her support for another research methodology. But perhaps there's a way we could better study, because what I struggle with is the relative contribution of the psychotherapy. For example, if you have an efficacious drug but a poor therapist, you might have a similar effect to someone who responds poorly to the drug but has an excellent therapist. So perhaps we need a larger sample size with a more structured, not necessarily prohibitive therapy. What links these comments by the different committee members is first and foremost a call to standardize the therapeutic process. Standardization is a key component of the epistemological practices of evidence-based medicine and randomized controlled trials. While there has been much attention to the rise of biological thinking in psychiatry and its links to psychopharmacological interventions like SSRIs and SNRIs, the rise of manualized therapy has not been given quite as much historical attention. I would argue that actually attending to this history and the various pressures are a key site for understanding what future of debates about psychedelic therapy might look like. So just in short here, I think some of these debates, I think we can put in context of the debates about psychedelics, but I think there's a broader context about what's been happening with psychiatry over the past since the beginning of the millennium that needs to be put in here. The rise of CBT and other manualized therapies in ways that displace kind of more open-ended psychodynamic therapies, I think is critical to understand apart what's happening here. What is more, the committee members' advocacy for a 2x2 trial design is not only advocacy for standardization, but also by studying the drug via studying the therapy. Dr. Amishai's comment about good and bad therapists hiding relative effects of the substance suggests that they think that the better way to study the drug is not a better placebo or designed for blinding, but more standardization of therapy. In other words, in order to gain the trust of pharmacologists, the way to study the drug is not to remove the therapy, but to vary it. What was perhaps ironic is that the committee members' comments hinted at a trust in the drug itself, but not the therapy or therapists. Multiple comments from the committee members noted their hopes for MDMA-assisted therapy in the future. Many acknowledged the participants for whom it had helped, and they praised the FDA in approving trials and beginning to study psychedelics. What they distrusted was the therapy and therapists. While the FDA did not ask the committee to consider a series of allegations of clinical and research misconduct, multiple committee members cited their discomfort about these issues in their comments. It's difficult to tell the degree to which these issues impacted the decisions of the FDA or the committee. It was clear that the discussions of ethical misconduct quickly slid into discussions of standardizing the therapy. Sociologist Thomas Guerin coined the term boundary work to describe efforts by scientists to distinguish scientific from non-scientific work. He argued that scientists perform such moves in order to consolidate their authority. Guerin's argument calls attention to the shifting norms by which the boundary between scientific and non-scientific practices is enacted. Contemporary work by science studies scholars like Wynne Ottinger have highlighted how citizen scientists draw upon the standards of regulatory science to do boundary bridging work and legitimize their findings. Certainly, efforts to discredit psychedelic research because of the lack of blinding can be seen as a kind of boundary work by scientists and psychiatrists. In previous writings, I've argued that debates about placebo controls are the site at times of boundary bridging work as well. The work of placebos and blinding procedures in the contemporary landscape of psychedelic research is not just about doing good research, but also about bridging the boundary between a humanistic and spiritual world of psychedelic therapy and the objective world of pharmaceutical research. However, the way that psychedelic therapy may ultimately end up entering mainstream psychiatry is by a standardization that rejects that boundary bridging work. At first glance, the FDA and panel's concern over functional unblinding and placebos may simply seem like a rehash of debates about functional unblinding and placebos from the 60s. However, as I've argued today, there is something else going on. Rather than an active agenda to discredit, there's an attempt to build a sort of scientific legitimacy around MDMA. But in building that consensus around psychedelic therapy, the thing that is distrusted is no longer the drug, but the therapy. Thank you.